Welcome to the PN2 Module 7 lecture on glucose regulation. Please remember that students are responsible for all materials in the resources outlined by the curriculum as well as ATI. This is a list of the objectives for this module. Take a few minutes and pause this and write down as many risk factors as you can think of for type 1 and type 2 diabetes. Have separate columns and then come back to me and I will add to you what you discover or what you have recalled. So if you want to write down table 64.5, that's a place you can go for some concise information comparing the two. When we talk about the risk factors for type 1 diabetes, we know that sometimes the cause is actually not unknown, but there are some signals or factors that can increase the risk, and that includes your family history. If you have a parent or a sibling who has type 1 diabetes, your risk of developing it are even higher. Environmental factors such as exposure to viral illnesses can play a role in type 1 diabetes. And then the presence of damaging immune cells or autoantibodies. Sometimes family members of people with type 1 diabetes are tested for the presence of the diabetes autoantibodies. And if you have those, you have that increased risk of developing type 1. But not everyone who has the autoantibodies does develop the diabetes. There are dietary factors that include low vitamin D consumption, early exposure to cow's milk or cow's milk formula, and exposure to cereals before 4 months of age. None of these factors, though, have been shown to directly cause type 1 diabetes, but the evidence supports that risk is higher. Geography plays a role. There are countries such as Finland and Sweden who have higher rates of type 1 diabetes. I'm wondering how much of that has to do with genetics as opposed to the actual geographic area of it, but the evidence does support it. So risk factors for prediabetes and type 2 diabetes include weight. So the more fatty tissue we have, the more resistance our cells become to the insulin. We know that inactivity increases risk as well. People who, even people who become diagnosed with type 2 diabetes, if they can incorporate a regular exercise program, they can often manage it without medication. Family history. So parents or siblings who have type 2, you are more likely to have type 2 as well. We're not really sure why, but we know that race plays a role. People of certain races, including Blacks, Hispanics, American Indians, and Asian Americans, are at higher risk. Our risk increases as we get older, so age is a factor, and this may be because people tend to exercise less, they lose muscle mass, and gain weight as we age, but we're also seeing an increase lately in type 2 diabetes among children, adolescents, and younger adults. And again, they're attributing a lot of that to inactivity and weight as we see activity levels decrease just culturally and weight increasing. So if a woman has had gestational diabetes when they were pregnant, their risk of developing type 2 diabetes later in life is higher as well. And if you gave birth to a baby weighing more than 9 pounds, you're also at risk. Weight gain during pregnancy is not specifically a risk factor. People with polycystic ovary syndrome, or women, I should say, they have an increased risk for diabetes. These individuals often, this condition is characterized by irregular menstrual periods, excess hair growth, and obesity. High blood pressure, so pressures over 140/90, are linked to an increased risk of type 2 diabetes, and abnormal cholesterol and triglyceride levels also play a role. So they have an increased risk of the type 2 diabetes. I just want to touch on gestational diabetes a little bit. So we know that women who are pregnant can develop gestational diabetes. They often do a glucose challenge test at different points in their pregnancy. I don't recall the exact weeks. I know you do. All women, I believe, do like a 1 hour challenge, and those who are high risk or who failed the 1 hour challenge might be called upon to do a 3 hour challenge. We know that women who are over age 25 have increased risk, and again, family or personal history, people who have type 2 diabetes increase the risk of developing the gestational diabetes while pregnant. And if a woman has delivered a large baby in a previous birth or had an unexplained stillbirth, that also can increase those risk factors. Being overweight before pregnancy increases the risk, and again, race seems to be a factor as well. Women who are Black, Hispanic, American Indian, or Asian American seem to have higher levels of gestational diabetes. In years past, age has been a significant indicator of what type of diabetes you have, or I should say, we saw more cases of type 1 diabetes in younger people, for instance, usually younger than 30. And then we would see type 2 diabetes more in older adults, but we're seeing more and more of the type 2 diabetes being diagnosed in even children. And so just be aware of that. As far as the difference in pathophysiology, type 1 diabetes, there are pancreatic beta cell destruction that's due to viral infection or autoimmunity, compared to the type 2 diabetes, which is more insulin resistance and dysfunctional pancreatic beta cells. Clinical manifestations for type 1 diabetes and type 2 diabetes can be similar, but there are some differences. Usually type 1 diabetes has an abrupt onset. The individual is experiencing thirst and hunger and increased urine output and weight loss. With type 2 diabetes, sometimes there's no symptoms at all. It happens kind of gradually over time, but if it goes undetected or untreated, you could see thirst, fatigue, blurred vision, vascular or neural complications, and typically 60 to 80% of people with type 2 diabetes are classified as obese. As we move through the rest of the presentation, it's going to be set up in a case study type format. So it's really important, if you're going to get the most out of this, that you do take the time to pause this and do some thinking about the situation and then move on with the recording to get the answers. I want to provide all of the content for you, but you'll get the most out of it if you do some reflection and even just take some notes along the way. So our first case study, we're going to talk about patient number 1, who's a 19-year-old who's newly diagnosed with type 1 diabetes. The college roommate reported the patient had the stomach flu, was drinking lots of water, was up often at night to the bathroom, and was difficult to wake in the morning. So the roommate called the parents, who picked up the patient and brought the patient to the ED. On assessment, the ED nurse found the patient to be dehydrated, somnolent. Vital signs are listed there. I won't read them to you. They noted fruity smelling breath and deep and frequent respirations. So think about which glucose management condition this patient is experiencing. And if you said hyperglycemia, you are correct. Before we move on to the next slide that's going to talk about signs and symptoms of hyperglycemia, please take a few minutes and jot down some of those signs and symptoms that you can recall. The signs and symptoms of hyperglycemia include polyuria, polydipsia, dehydration, tachycardia, fatigue, fruity odor to breath, Kussmaul breathing, which is the deep, rapid breathing, weight loss, hunger, and poor wound healing. The Kussmaul breathing that you see is the body's way to correct the metabolic acidosis that occurs with severe hyperglycemia, and so it tries to have the body breathe off extra CO2 to counterbalance that. Take a moment and think about what the nurse's first actions would be. Our nurse is going to need to start an IV and start a bolus of 0.9 normal saline. Labs are going to be drawn. There's a list of labs there that they're going to want to check out. And so if we go over to the right, you'll see this is a list of the lab results that we got. We have a blood glucose of 750. Our white cells are 11.2. H&H is 14 and 37, sodium 140, potassium 5.1, calcium 9.2, BUN 19, creatinine 1.1, and there are serum ketones present. The UA showed no bacteria or ketones. Take a moment and think about the labs that you saw and what you think that expected diagnosis may be. And since you know what we're studying, I'm sure it's not going to be hard. If you said diabetic ketoacidosis, you are correct. Now take a moment and think about the care of that patient and what we're going to do to help them correct this. This patient will be transferred to an ICU, or if you're in a larger hospital, you may have some step-down units that are able to manage DKA. We're going to be starting IV fluids to restore the volume. Now remember, this patient has voided a lot. They have polyuria. And so usually it's 15 to 20 milliliters per kilogram per hour during the first hour. And then they'll decrease it to 4 to 14 mils per kilogram per hour. When the glucose levels reach 250, sometimes they will switch that to D545 saline, not always. So you'll have to take a look at your protocol for the organization where you work to see how they want to handle it. But the reason that they switch to this solution, it's to prevent the hypoglycemia and cerebral edema, which can occur when the serum osmolality declines too rapidly. So this patient's also going to be on insulin. It will be IV insulin, regular, initially, and then once stabilized, they will switch that patient over to sub-Q insulin, regular, and then they'll probably start a long-acting at some point for them. Now remember, the only insulin that can be given IV is regular insulin. We're going to be doing hourly glucose checks and then adjusting the rate of the glucose drip depending on the results of the blood sugar levels. We do not want the blood sugar to drop too rapidly. We know the optimal rate of glucose decline is no more than 100 milligrams per deciliter per hour, so no more than 100 per hour. Lowering it too fast can actually cause cerebral edema, which is actually the leading cause of death with DKA. So we're going to be looking at potassium and replacing it as needed. Insulin causes potassium to enter the cells with the glucose, which will lower those serum levels. And so if it falls below normal limits, we're going to need to make sure that we replace that. It's important, though, to make sure that there's adequate urine output before we give IV potassium containing solutions. So your patient should have at least 30 milliliters per hour of urine output to demonstrate that their kidneys are functioning properly. Otherwise, we risk having hyperkalemia, problems from hyperkalemia because the body's not able to manage it. Bicarbonate may be used. It's not always used. So even though you're going to see metabolic acidosis, we're not automatically going to give the bicarbonate. A lot of times getting the glucose levels down can correct that acidotic condition that the patient is in, and that is sufficient. But in severe cases, they may order it. And then not initially, but at some point, we are going to consult the dietitian and or a diabetes educator for this patient. But in the immediate treatment of this patient, that's not the priority. Moving forward with our patient, on day 3, your patient has been transferred to a medical surgical floor and the nurse is called to the room and the patient has symptoms of feeling shaky and diaphoresis. What should the nurse suspect is happening? If you said hypoglycemia, you are correct. Take a couple moments here and jot down some of the signs and symptoms of hypoglycemia. Signs and symptoms of hypoglycemia include blurred or double vision, tachycardia, diaphoresis, reduced cognition. Patients are often very confused, sometimes even to the point of being a little combative. You might see tremors, some shakiness in the hands. They usually complain of weakness, sometimes hunger, headache, and irritability, and in severe cases, you can see a seizure. So what are we going to do about this case of suspected hypoglycemia? First thing we want to do is actually check the blood sugar. We don't make assumptions based on those symptoms. We want to rule out. This is when patients have those symptoms, the quick, easy fix is actually to, if it is hypoglycemia, is to correct that blood sugar. So let's get a Finglu or ChemStrip or whatever you call it where you work and find out where those levels are. If it is below 60, we're going to treat immediately based on the patient condition and the protocol of your organization. Patients who have mild hypoglycemia usually are a little irritable, they're hungry, shaky, weak, headache, fully conscious, and the blood glucose is usually less than 60. If the patient's alert and able to swallow, we're supposed to give them 10 to 15 grams of a carbohydrate. So that could be a 4-ounce juice. And then we should retest that blood glucose in 15 minutes. If it's still below 60, we need to repeat that treatment as long as they're able to, they're alert and still able to swallow. And then we should encourage them to eat a small snack or carbohydrate and protein if the next meal is more than an hour away. So we'll often give a patient, like if they're in the hospital, graham crackers and some peanut butter if they're able to have peanut butter. Even milk, there's some protein in milk that can help. So if they'll drink milk, that can help also. Do look at chart 64-7 for additional information. As an example, 4 ounces of orange juice has about 13 grams of carbohydrates, just to give you a point of reference with that. If your patient has moderate hypoglycemia, you may see cold, clammy skin, pale, rapid pulse, rapid, shallow respirations, and a marked change in mood, including drowsiness, and the blood glucose is usually less than 40. If your patient is still alert enough and able to swallow and cooperative, give them 15 to 30 grams of carbohydrates. So that would be, you would need to give probably 2 cups of juice for that. And then again, retest that glucose in 15 minutes. We're going to repeat the treatment if the glucose is less than 60. And then we want them to eat additional food, such as low-fat milk or cheese, after 10 to 15 minutes. In cases of severe hypoglycemia, or when the patient's unable to swallow, is unconscious, or is having convulsions, and that blood glucose is less than 20, the treatment will depend on where the patient is. So if the patient's at home, we want to teach the family to give a milligram of glucagon as an IM or sub-Q injection. So they should have a glucagon pen and should know how to use it. Now remember, it's fine that you teach the patient how to do it, but if they need this treatment, they probably are not going to be able to give it to themselves. So their support people need to know how to provide that care. They should give a second dose in 10 minutes if the patient remains unconscious, and then notify the healthcare provider immediately and follow instructions. If they are still unconscious, transport the person to the emergency department. If they wake up, or when they do wake up, we want to give them a small meal when they are no longer nauseated. So for patients who are in the hospital who can't swallow, we give either sub-Q or IM glucagon, or we give D50, which if you've ever had to give it, it's this big, huge, fat syringe, and the dextrose is really thick and syrupy, and so you have to give it really slow. And it's good that you give it slow anyway because it's caustic to the veins. If you have a central line, that's preferred that you give it that way, but a lot of times patients don't, so you want to give it slowly. And you really don't have a choice because it's hard to push in. So make sure once you have administered that you follow it with a flush to because there will be a lot of glucose sticking to the inside of your IV access, whatever it might be. And if it's a central line, you don't want to lose that. So even normally we flush central lines with 10 mLs, you may want to flush with at least 20 to prevent that from happening. And then again, we're going to check that blood glucose level again in 15 minutes and then respond to those results based on how your patient is presenting and what those blood glucose levels are. A very common question that we get asked is, when do you notify the provider through all this? So always remember, we're taking care of our patient first. You can send somebody else to notify the provider. In an inpatient setting, if your patient is unconscious, you want to call a rapid response and get a team there. You shouldn't have to manage this by yourself. So call that rapid response and get those experts at your bedside to support you with this. If your patient is alert, after the assessment and that immediate treatment, if they have mild or moderate, after you give them that initial treatment, you're going to be waiting for 15 minutes for the recheck, and you can notify the provider during that time as well. You can print this slide if you like, or I will be handing out some sheets during class for lecture just to have as a resource. You probably should have received this when you were in pharmacology class, but in case you still don't have it, I'm going to give you an additional copy of it. So as I mentioned earlier, regular insulin is the only type of insulin that can be given IV. And what I really want you to focus on for the test purposes, obviously I want you to know which of these insulins are fast acting, which are long acting, but I also want you to understand when the peak is. And the reason we want to know when the peak is because once this insulin peaks, your patient is at risk for developing hypoglycemia. So we want you to be able to know to go in and monitor that patient and looking for signs of that, so that if you do need to intervene, you can do it sooner rather than later. If two types of insulin are given at the same time, be alert for hypoglycemic episodes related to both of the insulins. So if you give NPH and regular at 8 o'clock, think about what time you would be assessing for hypoglycemia. So just take a minute, pause this, and just jot down, when would you be looking for hypoglycemia with regular, and when would you be looking for it with NPH? And so for regular, it would be between 10 and 12 o'clock. And NPH would be between 12 o'clock and 1600. So which insulins can be mixed? Think about that for a minute. Only NPH and regular can be mixed in a syringe. So if you have to give two insulins, you don't have to, that are not NPH that can't be mixed, you can give them. You obviously aren't going to put one in each hand and give an injection at exactly the same time, but you can give one and then give another. You don't have to wait a certain amount of time between them. Make sure you're not giving them in the same injection site. So if you're using the abdomen, use different locations for it, but you don't have to wait. So make sure that you know the order of mixing for the regular and NPH insulin. We're going to move on to our next case study. This is our patient number 2, who's a 43-year-old at the doctor's for their annual office visit, and it's determined that the BMI is 32, and labs are normal except for the fasting glucose is 140, and the hemoglobin A1C is 8.3. So think about what normal hemoglobin A1C is. Normal hemoglobin A1C is 4 to 6%. So which diagnosis would you expect to be added to this patient's list of diagnoses? If you said type 2 diabetes, you are correct. Our priorities for this patient during this office visit are going to be education about glucose regulation, so they have an understanding of how to control their glucose levels. That'll include nutrition therapy, pattern management, so teaching them how to take their blood glucose levels and giving them a log or a journal where they can write it in and see the trends, getting them to keep a food journal along with it so that they can see the correlation between what they ate and then how their blood sugar responded to it. Often these individuals are started on oral hypoglycemic agents. We'll talk about them a little bit later. And so making sure we provide that thorough education about it. Very few are started on insulin with initial diagnosis, but it's not uncommon as the disease process continues, especially if it's not well managed, for the individual to need to have insulin. Some patients are able to manage their diabetes without medication just by making those lifestyle changes such as dieting, exercise, and weight management. And we're going to want to consider referring them to a registered dietitian and a diabetes educator. And if in situations where patients are having trouble controlling those glucose levels, even when they are on those oral hypoglycemic agents, sometimes setting them back to the dietitian or diabetes educator for additional teaching can be helpful. People have to hear things several times before they can make those changes. And it's often helpful for them to have experienced watching the changes in their blood glucose levels with the lifestyle choices they've made, and then to hear again a second time how they can improve and better manage the diabetes. So don't be afraid to send somebody back to the educator or the dietitian. There are many oral hypoglycemic agents, and if you go to chart 64.2, there's some really good information in that. I'm just going to go through some key ones and some key teachings or adverse effects that you would want to know for these patients to make sure you include in your teaching. So for your glipizide, patients should avoid NSAIDs. This can increase the effects of the glipizide and cause blood sugar levels to actually get too low. When taking metformin, people should avoid alcohol, and this must be discontinued before certain imaging tests where contrast is used, and then not started again for 48 hours after the testing. This can cause kidney injury, and sometimes for patients who already have some renal insufficiency, they may check their renal function 48 hours after they get the contrast before resuming it, just to make sure they're doing okay. The DPP-4 inhibitors instruct your patient to be alert and to observe for rashes or other signs of allergic reaction, because this class of drugs has a high incidence of drug allergy. Your sodium glucose cotransport inhibitors, that's a mouthful, teach your patients the signs and symptoms of urinary tract infections. So with this type of oral hypoglycemic, it causes the body to actually excrete the extra glucose, and so there's increased chance of urinary tract infections from it because there's so much more sugar in the urine, and bacteria loves glucose to grow in. And instruct women to be alert for any genital itching and vaginal discharge, because they do increase the risk for genital yeast infections. Moving along with our scenario with patient number 2, a month later, patient arrives at the ED with an altered level of consciousness, frequent deep breaths, and the family states that the patient had a stomach virus. What are the nurse's first actions in the ED? We need to get a full set of vital signs. We're going to do a quick health history and check that blood glucose level. Additional labs will be drawn, and same ones from actually our first patient who came through. And then we want to get that IV going with 0.9 normal saline. On assessment, it's determined that this patient's dehydrated, they're somnolent, vital signs are listed there. You're noting that fruity smelling breath again, rapid deep respirations, and the blood glucose is 840. ABGs show a pH of 7.45, PaCO2 of 34, and bicarb of 23. Serum osmolarity is 380, and there are no serum ketones present. The UA shows no bacteria or ketones as well. What diagnosis would you expect for this patient? If you said hyperglycemic, hyperosmolar non-ketotic syndrome, or HHNS. You are correct. Years past, they used to call it HHNK, but the new preferred term is HHNS. Notice that the blood glucose levels are higher with HHNS than the DKA. And it's also important to note that your patient may have seizures and actually reversible paralysis due to the neurological impairment related to the serum osmolarity. Coma can happen when that osmolarity is greater than 350. How are we going to treat HHNS? If this slide is familiar to you, it's because the treatment for HHNS is pretty much identical to how we're going to treat DKA. Notice that with HHNS, there were no serum ketones present, but there was with DKA, and that is because the pancreas is still producing a small amount of insulin, which prevents the development of those ketones. But otherwise, everything's the same. The speaker notes that I would have given you are the same as for DKA, so I'm not going to read them to you again. And this is the end of our presentation for Module 7. We'll have some activities in class, and make sure you take a look at those charts.